diseases is not merely close to the high economic income individuals, but also present in between low and middle income individuals in Indonesia. And we know that Malaysia and Indonesia is having a similar characteristic. So I think this topic will really give us insight to how we can approach the situation in Indonesia according to the experience from Kuala Lumpur. And so please, Professor Hazreen, I think the time is yours, and uh, I think all participants. So if there are some participants are interested to join, so just please join, but please mute your microphone. Thank you very much.
Okay, good morning and assalamualaikum to everyone and salam sejahtera.
Waalaikumsalam.
Thanks to Dr. Adrian Pramono for the kind invitation, and also to the Department of Nutrition from what we call it, Undip, for having me for the second time. As rightly said by what we call Dr. Adrian, there are some similarities which I think is good for us to share. What is something that you can adopt is something that we can actually learn from each other. We also need to learn from Indonesia, so don't worry. It's actually both ways, yeah, Adrian, not only just from us. So let me just open my PowerPoint slide and share. You can see, can you see now in the full space?
Still in the not in the full screen. So I think you swipe displays, please. You can click swipe displays in your screen.
Top displays.
Yeah, perfect.
Okay, so this one, understanding the NCD risk factors in urban low-income dwellers in Kuala Lumpur. So this project is actually a project that we have been doing it since then 2012, and then we are just finishing up some of those intervention study. When we talk about urban low-income dwellers, it means that those who have who are staying in the city center. Previously, some is actually living in, we call it like a slum area or setinggan, but then the government provided them the house, which is low cost, and at the same time they have to pay very minimal fee. So because these places, some of them are very close to the University Malaya, we are also doing our part in helping them so that they know whether they are having NCD risk factors or not, and they can take their own action. But before we go very detailed towards that, I also would like to talk about when it comes to food, is it got to do food related behavior? Because you see, we know with certain characteristics for those who are high income, but how about those who are low income? So is it a matter of to curb any issues related to non-communicable diseases is related to food-related behavior? Is there any relationship between health and food? Because sometimes people say, healthy food expensive. Is it true? That is not my focus today, but just to highlight to you, there are multifactorial that leads to people having good, high-quality food. Late themes with regard to health, functions of food, influencing food choice, and then only we will talk about from the studies we discussed, because this take us for a few years to get some information, is the unhealthy eating practices among this group of population, low-income urban dwellers. And we will learn a little bit, because remember from my previous talk about the adolescent cohort, that maybe also can influence when they are moving around in the city center, but that is not what we investigated, but just try to relate it. Is it beyond food-related behavior? And then we come to the discussions and conclusion. So let's start a little bit about the food-related behavior has always been defined and measured in a variety of ways, either by we are selling the food, by we are the one that we purchase, and also some people, this is not something that we have to do, we poison the food as well. Okay, but when it comes to food-related behavior, food beliefs such as linked to choosing and how you prepare or how you cook and consuming food, that also can lead to your food-related behavior. And most of research on consumer food-related behavior is in the areas of food choice, food hygiene, and food consumption. And why do I relate this? Because some of us, or maybe majority of us, when we purchase food, we don't look so much in terms of the ingredient, but what we look into is the expiry date and whether it's safe to be consumed or halal. Food and health relationship, food-related health often framed in terms of morbidity and mortality statistics. Is there any that we don't have any diseases? Or maybe interventions which can restore the body to normality. So I'm not an expert in the food-related behavior, but just to share with you. So look into here, when you are looking at, I'm trying to put it into my laser color pen, automatic laser pointer. So there is some awareness we have to look into where is there any need to change, but how are we going to evaluate them? We need to start from our beginning evaluation of the situation, which is actually the low income group. Is there any choice? This is currently what I'm also helping with other group in terms of digitalization in promoting health promotion. Purchasing supplements, whether it's important or not, is there any regular use of supplements that will lead to your intake of micronutrients? And eating behavior can come from your meal patterns and eating habits. All this eating behavior at the end will lead you to the outcome in terms of health outcome. Examples of behavior changes related to changes in folate intake, for example, you provide them the choices availability for the individual. Because, for example, those who prefer to have it from the food, they will purchase the right and the good food. Those who are actually going to have products where public health interventions trying to incorporate, and from the nutrition point of view, they will fortify the food and with folic acids, and we encourage them to have certain foods that is high in that, or purchasing supplements for those who really want it. So this coming back to the example of behavior changes in terms of providing the choices. How about meal patterns and eating habits? Switching from refined grain products to whole grain products, that requires some willpower, because if you are from young, have never been exposed to whole grain products, you find it very difficult to change. Increasing the use of whole grain products as snacks. Maybe if the child of nutritionists, dietitian, and medical doctors and within the fraternity of healthcare, yes, it's easy to encourage them. But when the product is available that is unhealthy at schools, the students will also explore those food that is not healthy, and then possibly will reduce the usage of whole grain products. Increasing green vegetables and dried greens in meals. That is also some of the eating habits that needs to be changed, but it will take some time, and the list goes on. From my previous talk, I had highlighted when we are from our Malaysian adolescents who skip their breakfast, we had associated those who are having breakfast will have a better reduction in energy intake, improve in terms of the food choices, possible improvement in the circadian rhythms because they are having better sleep. They did actually have lower body weight, better glycemic regulation, and if we evaluate it in the long run, potentially it will be better also in lowering the long-term cardiovascular disease risk. But when we're talking to layman or lay teams with regards to health, we also have to explain a little bit the definitions of health, because the way that we explain to them, maybe for them, as long as they can move and move around is actually good enough. But what we are talking about, as long as they don't have any diseases, explain to them and how is it going to be maintained. And there are a few other things that possibly we cannot control. For example, the food that is available here, despite of us trying to encourage healthy food, if eye level, you can see all those unhealthy food or easily to access to this food, and also those foods being highlighted in the advertisement, the tendency of people going to have them is greater. So the definitions of health, normally we will always need to reiterate to layman, is actually the absence of illness, whether you can be able to carry out your daily work. Is it equilibrium in terms of your health, means that you're fine. And health is also a freedom, the capacity to do so. Otherwise, you are always bedbound. So the lay themes when regards to health and how health is maintained, some people take it, health needs to through meditation, which we respect to that. The thought for my today is, before I'm going through to the urban poor, what is the issue, it's good to know a little bit as a general. Health is dependent upon mental attitude. With some of our outcome later, you can see whether smoking play a role. Health through working, because the more that you network with others, you might actually be a positive thinker. Religiosity and supernatural explanations, possibly with certain types of, or with certain group of people. Health can also be maintained through rituals, and poor health is own fault, which people normally will assume why you're overweight, obese, because you don't move much. It can be hurtful, but sometimes this is what the layman is looking at. When it comes to lay themes with regards to health, it's also from our part that we can influence is when it comes to the policies and also institutions, we try to educate using our findings. Health is affected by the environment. Definitely, I'm sure in Indonesia, there's a lot of huge group of people who are looking into this and working with Ministry of Health. You are looking at how the environment looking, which I'm going to give a little bit, and health is genetics. This is something difficult because people will assume if they are overweight, obese, got to do with genetic, but normally it's not so much just the genetic. Yes, it can be true for some, but it's just that sometimes they don't run, okay? And the place that health occupies in people's lives can be also priority placed on health and nature for the lay health beliefs. So coming back to that, before we go through in terms of from the food point angle, functions of food, we know because most of you guys are the expert. It comes to look into physiological for you to move, and it comes from your biology and also nutrition. But don't forget, for this low income group, or even though for us, we do have social and psychological. Whenever we go out, we always ask people to actually eat. Very rarely we're going out asking people to jog. Even though if you run for a marathon, I'm not sure about in Indonesia, but in Malaysia, before the COVID-19, there's tons of marathons every 2 weeks and people make money of it, which is good, people being active. But what you should look into it, because of the social gathering after that, people tend to eat at the 24 hours eateries, which is providing high energy, high dense. So social and psychological also play a role because food normally will be provided for the social event. Given the complexity of behaviors and multiple determinants, identifying the routes to achieve desired behavior change is the key challenge. We are still struggling, but we are slowly trying to understand how to improve it. Because most of the time, if you are using traditional methods, social marketing, education, aim at individuals with little emphasis, it won't work because you need other things that go hand in hand. Consensus are more sophisticated when it comes to interventions are needed for behavior. Because for example, if you are doing some studies, you look into physical activity, you look into the diet and everything for intervention. But if we ask properly, which one that really worked, a lot of us wouldn't be able to say because most of the time we are trying to make it as a complex intervention. Need to understand the mechanisms that underpin the various interventions. And this is what I'm trying to highlight. So when it comes to behavior, I mean, for Malaysia recently, our Ministry of Health picked it up saying that for Malaysians who are having more overweight, obesity and cholesterol problems, and we are not very well, one of the things that he highlighted is actually behavior change that is needed, which is true. But as you are the one who's working, I mean, for majority of us in this area of health professionals, yes, behavior change is important, but few other things are also important. So behavior change interventions are trying to increase physical activity, which is commonly done, adherence behaviors, can be quite tricky. And screening attendance, for example, are normally what we are looking at. For example, if we are giving intervention, they are coming or not to listen to our talk, are typically complex because each one of these involve many interacting components. And then what we really need when we are doing such studies, the methods in specifying and reporting the complex intervention, what we need to understand. And now more and more of my PhD students and DRPH, I'm encouraging them to look at in terms of the right model before they are going to embark on their work. So I'm not the expert for this, but I'm sure some of you there are. But I just like to put in terms of the Kombi behavioral system, looking at several ways. Physical, your capability. Kombi means that your capability, opportunity, and motivation. Because behavior can also look into your capability, whether you can do it, you can comprehensive look into it. Some people are looking into health literacy. They are saying that by having improvement your health literacy, you will also improve in terms of your not so just practices, but also evaluating your action. Reflective process, which is actually motivation, which is can be very challenging, and also opportunity. This is what most of academicians try to have a look. Is there any way that we can improve environment? Is there any way if we are actually changing the way we put our snacks and drinks? Because socially, it can be afforded by the cultural milieu that dictates the way that we think about things, okay? So I'm just taking an example, obesity. I think I've shown this before, and I mentioned to you earlier on, Indonesia is doing well compared to Malaysia. And Malaysia now for cholesterol level, 1 out of 2 our adults are high in cholesterol. But when you really look into it, because I'm putting this aspect as a broader picture before we look into the low income, you see, if they are having problems with NCD and obesity, it's not just individual physical activity, you have to look at it. Where do they live? The environmental activity, does it permit them to move around? Individual psychology, are they ready to make the changes? Because health professionals normally just give a answer, you should do this and that. But if you understand them properly, oh, hang on, you should by right improve 1 or 2 first before you go A, B, C, D, E. Societal influence, because there are people or there are some society saying that if you are underweight, it looks like you are not very healthy. Food production, I'm not sure about in Indonesia, but I guess both of us the same. We always have a lot of food, new food that is coming out. How fast we can actually cope up with the changes in the dynamics of food production. Food consumptions, sometimes even though you're not hungry because your friends offering, that you also overeat. Biological, physiologically also plays a role, especially when you're having foods that is not very healthy. It promotes certain what we call it, microbe in your gut to grow, and those gut microbiome can be the unhealthy one that leads to more pro-inflammatory biomarkers being produced. So obesity is a complex and multifaceted. And also another thing, before we go beyond about the adults, we look into from our young. This is not just focusing from our low income group. This is an overall from both urban, rural. Look into here, which I had briefly explained, sometimes from young. As an overall, we know physical activity, people have gone down for both gender, male and female. But why? The question we want to ask. For female, the what we call it reduction of physical activity among rural is becoming even more compared to those who are living in urban. I did explain a little bit from the dietary intake between the rural and urban. Majority of them not having enough fiber, but as a rule of thumb, the rural, what we call it, adolescents having higher intake than the urban. And if you are having higher intake in terms of energy and also poor in fiber and also quite high in sodium, and you're not active, you are having the risk factors leading to the more non-communicable diseases. And I like to put this information again, and most of the times our energy comes from the excess for these kids are the unhealthy one, which we can do something, either from policies level or even though in some countries they are doing some sugar tax, okay? This is I mentioned to you earlier on, and this is what I said, And this is how do we derive that information. The food and drinks that they consume for breakfast, normally from cereal-based mixed meals, which is good to have when it comes to cereal, but whether it's prepared healthily, that is number one that we have to ask. And second one is also whether it's high in energy. But then again, rather than them not having it, is an issue, because those who are not having breakfast will lead them to having, those who are not having, having higher BMI. If this group, they eat breakfast frequently, they are better, lower BMI, lower plasma total, and lower LDL cholesterol concentrations, which is good. And this is also very important for us to investigate maybe in Indonesia, because most studies we look into, we know from studies, if you eat breakfast, your body weight is lower. But very few studies are looking into blood profile, and we can learn a lot. And this also leads to my presentation for the adulthood. We talked a little bit about the environment just now. The distributions of food outlets and physical activity facilities. This is a study by my doctor in public health students. We look into from the 15 schools, food facilities in terms of the distance towards healthy food. And school majority with the highest obesity, especially rural, there's no physical activities facilities around the 2,500 meter radius from the school. So you see, within 2 kilometers, you can't find any place for you to go to the park to exercise. So what we do, either we need to have a park or we need to make it a place that is safe for them to walk to schools. School with the highest obesity in urban also, no physical activities for adolescents found within the 2,500 meter radius. So at the end of the day, whether you're urban or rural, it is not very conducive environment for these school children. And possibly rather than looking outside of the school, we should utilize what is within the school compound. So the majority of, yes, any questions? I heard a voice just now. Any question? So the food outlets, sorry? So the food outlets, the majority of the adolescents, more than 70%, spend more on food from outlets within school. So school canteens. This gives us an idea. If either low income or urban, we should improve from our school canteen as well. And also we found from that 14 school canteens were selling high energy density food. Coming back to food that they need to actually make it healthy options. Even though we do have our guidelines, what are the food to be sold at school, there are some still who are not obliging to what we are recommending. And for physical activity facilities, female adolescents in this time did not frequently even use physical activity facilities located outside school, and let alone, because you know sometimes in the school, in our school, sometimes with the syllabus, they put it there for you to move for school physical activity, but it's normally replaced by any other subjects, okay? I'm not talking about that because we do have 2 papers published for that. If you're interested, can have a look. Now, giving you the overall picture from a little bit about school, a little bit about behavior. Now we come back to these adults who are low income. Bear in mind, they are low income. They are living in the city with a very, very high pressure to work. They're also having a space that is quite confined, about 800 meters squared, what we call square foot or square feet for them to stay with maybe family of 4, 5, 6, 7, you know. So this is where, when we are doing this study, it's actually been initiated, the university is asking us, why don't we work together with the low-income community? It is work with this study, which we call it partner, is participatory action research through negotiation and empowerment of the residents, which is good. You can have a look at the protocol, what we did, and hence now I'm going to start with the low-income group. So the target population for this study, we are focusing the lower socioeconomic groups and urban migrants residing in Kuala Lumpur. We did starting from back then, 2012, and we chose, when I put PPR here means Project Perumahan Rakyat, or in English, ataupun namanya dalam bahasa Inggeris is Community Housing Project in the Lembah Pantai where we selected. Lembah Pantai area also is where the university is being located. So the community housing project is some sort of like an initiative by the government, because there is a shortage of housing and slum problems that started in 1999. We are providing them, and each unit have about 800 square feet. And up until 2010, that's about almost 30,000 units PPR were built. And the 2020 numbers, what we call it, has not been shared yet. So household survey samples from these 800 households, because you have to remember there are several places, so we need to have representative from each PPR that we went. So we did a multi-stage proportionate simple random sampling. We got all the lists from DBKL, which is actually the city center municipal. So you need the list, and then we are trying to look into how we're going to have a proportionate simple random sampling from each. And then what we collected is the most important thing. All the questionnaire, we do some training, we take all the social demographic, health service utilization, and healthcare expenditure, which is not part of my topic today. Focusing more on nutrition food practices, where we interview the household head and spouse. And it comes to nutrition especially, very important to interview the mothers. But bear in mind, the mothers is the one that you interview, but don't forget to ask the fathers, because the fathers who's the one buying the food, or they give the money. So the proportion of money should be focusing on which one. That is also very important. And then we also have a module which is looking into the cancer awareness. Okay, there are a few others that we have. We have about until 10 modules, but let me just tell about the 4 modules, or not just the 4 modules, few modules related to nutrition for my talk today. So before I continue, is there any question, or am I talking too fast? Because just now there are people who are almost like asking. Adrian, is it okay? My pace, is it slow, too fast? Dr. Adrian? Saya bercakap laju ke?
Yeah,
Just nice? Is it okay?
yeah, it's okay. I
All
think
right.
the pace is okay, but let us hear from audience. Maaf, apakah Pak Hazreen ketika menjelaskan terlalu cepat?
Or you understand or not? I can make it both in Malay, English.
Terlalu cepat, Bapak.
Okay, so yeah, it's one of audience say that it's too fast, so
Okay.
maybe a bit slower pace.
Okay. No
Yeah,
problem.
yeah,
But
thank
before
you.
no problem. Any questions to begin with before I continue? Because now we are,
Okay,
yeah.
any questions? Because just recently, Dr. Hazrin has explained about the design and the background, and now he is going to explain about the results. So before that, if you have any question, maybe from the methodological aspects or the background, please, you can raise hand.
It's okay. If you don't have, I
Okay, if you
can
don't,
keep it.
yeah,
Keep it.
please continue. It's fine.
All right, thank you. Okay, so when we look into the low-income individuals, so what we did also, we collected their body weight, ambil beratnya, ketinggiannya, and also we collected the blood. You always have to remember, most of the times, even though our National Health Mobility Survey, they also collected either finger prick or certain thing, and we collected the blood pressure too. And what we see daripada kajian from this low income group, you look into this diagram. So as a result, obesity from this group of low income, 55% of them are overweight obese. This is low income, yeah. So when we know the problem, then it's easier for us to plan what we want, rather than we say we want to do program and straight away just go. Hypercholesterolemia, not far from the Malaysian one, it is actually 51%. Okay, we discover almost similar to the one from the National Health Mobility Survey that they actually doing for the whole country, and we are just doing it from within the what we call it Klang Valley. And hypertension is slightly higher from this group, because our national is about 33%, here is about 39%. And these are the common CVD risk factors among the low income respondents. What we notice also, almost 20% of them smoke, because you are living in the city, you are stressed, and few other things. Okay, education level, Diabetes mellitus is about 7.8%, and alcohol consumption was the least. And if you look into here, it's actually the male have a good proportion for almost all diseases. Okay. Next slide. Now, besides then, I'm actually just talking about diet. I just put 1 or 2 slides to look into the other public health issues. So the prevalence of smoking and determinants chance of psychological problems among smokers in this group. Okay, this is a study that I had opportunity to work together as well as with the group from the Center of Addiction they're using here. But you look into here, the relationship between smoking and depression. Those who are depressed or those who are smoking are 1.3 times higher on getting depression. Those who are who also reported smoking are 1.4 times who are actually anxiety or anxious, and 1.2 times is actually 20% higher in getting stressed. So you see, understanding the background of our population that we're going to investigate, if they are smoking, they have a tendency of depression, anxiety, and also stress. So when we are doing some intervention, especially for me today, I'm talking about nutrition intervention. In fact, I do have another project looking at how in terms of mental health during COVID-19, which I'm not sharing here, it is also quite alarming. Then using that information gives us some idea. Okay, let's look into the dietary practices from this group of what we call it population. So this published in International Health. So when we look into the dietary practices, we try to make it in terms of when it's unhealthy, they fulfill things such as adequate enough of fruits and vegetables, having enough carbonated drink, or not having high carbonated drinks, whether how often they consume fast food, and dietary practices. And what you notice here, of course, we know, I mean, maybe Indonesia much better than Malaysia. Malaysia actually from this lower income groups, 86% having less than 5 fruits and vegetables per day. I guess this is also a worldwide issue, okay? And of course, they say that they don't have the carbonated drink so much, okay, which is fine because this is reported. But when we put the scoring for female, looks like they are having the most unhealthy dietary practices. So when we know this is the issue, we should start to target. We cannot do so much of intervention. We have to focus. So the healthy lifestyle intervention should be highlighted so that it can be adopted in low-income group. So here, at that time, we're trying to look into the effectiveness of lifestyle modification and peer support home blood pressure monitoring, because that will be for monitoring in terms of hypertension for the from public health point of view. And if you are interested, we are using the protocol for cluster randomized control trial because you actually having several low-income urban flats. Bear in mind, for this low-income urban flat, despite of we are having a good design, it's very difficult to get the numbers at the end. So let me just briefly go through with you. So from that 4 random selected community housing complexes, we are targeting intervention from here, about 160 control, and we're having evaluation baseline 6 months, 12 months, and we want to measure the blood pressure. We use the dietary assessment using the 3 days food report, some physical evaluation, and we also encouraging, or we provide in terms of the head of the, let's say that floor, have one person who has the blood pressure monitoring, so they can actually help people to look into blood pressure. But at the same time, that is part of our community services. We also provide the blood pressure monitor for them. And then we did data analysis. However, when we are trying to recruit from the control group, it was an issue. We couldn't get the numbers, and this is actually work from another student. We have a bigger project, but one of the small project is given as a PhD project. And because of we couldn't actually get enough numbers from the control, and it take longer, okay? Because even though within 2 years, we managed to just get it certain numbers and very few from the control, we just had the opportunity to do studies just looking from the what we call it prior intervention and post-intervention. And we look into the improvement of nutritional intake for the low-income urban dwellers with hypertension in Malaysia. So what we did is also, the participants, we divide into small groups. We did both in terms of qualitative educations, and also post follow up with the interview. We look into, as I mentioned to you earlier on, the dietary intake and exercise, and some of them receiving SMS reminders, because that's going to give them some information. And we do have, you see, just at the baseline is enough, even though after 2 years, this is the maximum that we managed to get. And majority, the female who participated most, and the age group, we managed to get most who are from the 50 and above. But looking into from the body fat percentage, the overweight obesity is almost or 90% from the group that we recruited, which is already high. Let's see what other changes we'll see between those three. So the energy intake, yes, it has reduced after we giving several education sessions we did with the group. Okay, protein intake has reduced. In terms of carbohydrate intake has improved, and the fat also actually has improved. We are using the tool that is already make it suitable for the what we call it, for the education to be explained from Malaysian context. So we use several, and we look from the Ministry of Health and try to actually use that information. Of course, we had pre-tested them. Variables, we are looking into the change blood pressure. You see, this is one reason why if you are just looking into the blood pressure, it's not much of a changes, despite you can see almost going down, but because it's not significant, I wouldn't want to say it is actually reduced the blood pressure, but it's good just to give you some idea. However, when you look into the blood biomarkers parameters, because sometimes when we're talking about diet, people can report, people can just say they are reducing the food, but you can slowly see in terms of the fasting blood sugar, of course, there's some reduction there, and the renal sodium, you can see, and also with the TG profile, it's actually the most actually had reduced to 1.59. Okay, I also, just to highlight, sometimes with academia, it is very important for us. I mean, I'm sharing with you, but I just put this slide to share with you. Sometimes in academia, it's no point that we are just sharing between our academic and also with the Ministry of Health for our profile. But it is good if we can incorporate. This is just been highlighted earlier this morning. Today is 12:21 a.m. Sharing my work from the in terms of metabolic syndrome among the children, and also highlight a little bit about unhealthy of our Malaysian, because now Malaysia is moving towards a more healthy awareness population, health awareness population. Now I'm bringing back with all those information. Well, food-related behavior, is it a question of health? So you look back, I mentioned to you earlier on about the combi, your behavior got to do with capability, opportunity, and motivation. It gives us some ideas. Sometimes when we want to do in terms of education, we need the people, or we need manpower with the capability, and we must empower the people. Then when we empower the people, we have a reflective process looking into that, and then we hope with the motivations that we give, it also motivates the people to make improvement. But how? By looking into the problems earlier on from our cross-sectional study. We are looking at what we can do, what we have with our money, some opportunity that we can do, especially to improve in terms of the issues within the low income group. How we are looking into that when it comes to this capability is always the education by increasing knowledge or understanding. In fact, it's not just the knowledge. You must make sure that the participants really understand and can appraise that information. And that is where the health literacy plays a role. And also, when we are working with the municipal, if it's not working in terms of the environmental structure, because when we did our work 2012, there's not even playground near to their places. But then 2-3 years after that, the government has allocated a plot of land that is meant, let's say, for sewage in the bottom, but they make it a park on top of it, which is better use of the land, and people can exercise there. So with this environmental structuring that we need from automatic process, physical and social, changing the physical or social context by providing prompts to use labels via mobile, like we did a little bit, and then phones upon entry into supermarkets. This we didn't do for the entry to supermarkets, by educating them what is important to have is where we look into as the opportunity. Definitely, we need to do training where we impart skills, not only just for, because we are doing series of education, including to ensure that they can read the labels. And I'm sure either in Indonesia or Malaysia, we are always within the Ministry of Nutrition, Ministry of Education, Ministry of Health, and the Nutrition Division. These are the things that we highlighted often, and things are what we call it being updated every 2-3 years. But what is important here is not just between us understanding the food labels, we must make it the public can utilize it as well. And all this Kombi is definitely looking into the modeling where we use TV drama scenes involving nutrition label usage, not from our part, but in our case, we are trying to work together. For example, I also am going to be featured tonight within the Didik TV, means that the education from the Ministry of Education. So you see, we are looking into the way that we are educating, must use as much as possible all the linkages, the media that we can. But in the same point as well, we need to highlight to the policymakers the importance of to do some restrictions. For example, now in the Ministry of Health, we are our Minister of Health, in fact, now are asking whether the food should be available 24 hours or not. And majority respondents should be, which is a bit unfortunate, but then people need to understand why it's important to have such restriction, including screening time for children. And all these things, when it comes to motivation, we need to look into how persuasive we are. Either we want to motivate using the healthy food, how we are actually putting together rather than raising the financial cost. Is there any possibility we make food that is healthy, bit cheaper, and we look into that for school children that we did before. It worked, okay, but on a smaller scale. We haven't done big scale. And then incentivization. For example, if you are going, because now we have apps, if you're buying more healthy food, can you get some points? And then those healthy foods, when you purchase another food in the future, you can get reward. Because if you look into our Grab or whatever Food Panda in Malaysia, most of the foods that has a lot of discount are those like donuts and unhealthy one. But the one that has a very small discount is actually food that is healthy, like your salads and everything. So things like we need more willpower for that. Maybe for future nutrition labeling research can also assist for food behavior change. Why I'm choosing this, because we are looking at the bigger picture now, because we know in Malaysia, besides that behavior, which we are always struggling, but we need to have something that we want to convey to our Ministry of Health. Is there any possibility that we want to encourage other things that is available that we can use to assist with food behavior? Why is the current level of usage of nutrition labeling may not be higher than this? Because it requires a shift from focus on information processing to an approach emphasis motivational issues. Because currently we look into the size is small. Now we have the front to back to front labeling, which is good. But at the same time, you have to understand people might not have so much of information. Do we need food industries to play their role as well to minimize unhealthy food? Okay, to minimize salt content and sugar, which I am involved with another study, which I'm not focusing here. When nutrition labeling is information needed, yes, it may require shift from the study of individual product, and also we want to emphasize actual consumption. It is interesting from my work that we did for the policymakers, when we ask people, oh, do you understand about our food label? Do you understand about healthy food and a few others from the ministry? They say, oh, they never heard about it. And these are people from the ministry. But when we are talking about, for example, how much, which products should we buy that reduce the energy consumption, everybody knows. And they are referring to a technique that is easily to remember. So you see, for me, working with this public health and nutrition-wise, it makes me actually think about slightly outside the box, rather than we are so focused with our nutrition colleagues until we didn't actually think about from how other people perceive and understand from our point of view, which is very important. So the discussion here is actually food choice behavior is habitual, so harder to change through information provision. You have to reiterate all the time. And I think some of you here are very, very expert in this area. So this is what from my observation and my limited information and that I know. Whether habitual or carried out consciously for food choice is not related to health when health is conceptualized as disease prevention unless it is personally relevant. Because some people, you need a little bit of touch. For example, you're saying that, oh, this make you cancer. They don't care. But the moment you say, oh, this may be actually because of the cancer that affects some of your relatives and things like that, then they will actually slow down and think about it. How do we make food-related behavior personally relevant to the majority? Some people making changes because of personal, but what we want now, they are the motivator towards others. Conclusions, they take into account of consumers' relationship with food, the social economic issues, very broad, yeah? Increase relevance by addressing broader range of meanings of health when designing intervention programs. And sometimes, you see, with the one I'm talking about smoking just now, it's not just smoking. In that group of people, they are also having other issues. Some of them are also users of drugs. And that's where I'm actually incorporating here emotional, spiritual, and the more positive aspects of health should be part of the well-being. Because by understanding them, going to the level of the consumers, it helps us to plan properly for our intervention. So food-related behavior is a question of health, yes, but it needs multiple stakeholders to play their role. And I guess having to see your faculty of Department of Nutrition in the medical school, that is a fantastic opportunity because you do have a lot of people from psychologists, from the doctors as well to work together in order for you to enhance your work for the betterment of the society. So how can the government, as an overall to go further, how can government support healthy food preference? This is where we play our role as well because we develop and we know about the food policies, possibly with tax unhealthy foods. In Malaysia, I think in Malaysia, Singapore, not yet Singapore, in Indonesia, not Indonesia, in Malaysia, Brunei, and at that time possible Singapore, we have started our tax for sugar, okay, for not for overall food, but just for the drinks, okay. Restrict marketing to children, still work in progress, but if you look into here, we have to improve from the schools. I did mention from my previous talk all about the adolescent cohort. We need to do some regulation, or we work together with the Ministry of Agriculture. How we are talking about all the food-related behavior that is more towards individuals. We must make retailers as part of the team and the food producers, because we are educating, giving food labels. But if the food producers are not sure what is healthy or not, they keep on adding more and more salt and sugar because that's what people like, for example. There must be a strategy because other people has done it and it worked, okay? So I like to put this. I finally found a diet plan that really works for me. It's called the price of the food, which I think people will agree, okay? And also maybe for us, maybe not just the price when we have the education, okay? And I hope everybody, this is, you can tweet, take my tweet, and I hope you enjoyed my talk. And that's about it. Yes, it's more session for Q&A after this, but let me stop sharing. Stop share. Right.
Thank you very much for very interesting talking to from Dr. Hazreen to us about how we can address the behavior of community, especially those who living in rural area, to get more information, but not only one side, but to understand how they behave in relation to food, diet, and nutrition. So please, if I give the opportunity from some of you to ask the questions. So for those who Sorry, please. Okay, for students who are working or having experience to study about the knowledge, the practice, and the behavior, I think this talk is also relevant for you. So perhaps if you have any question or if you want to continue your study in relation to nutrition and food from the community, please ask. I think with respect to the methodology, you have a lot of opportunity to explore from the expert. Or you can also ask in Indonesia. Is that okay, Prof. Hazrin? If
You can ask in Indonesia, bahasa Indonesia. Kalau saya
yeah,
nggak paham, nanti
then
somebody,
I will help you.
ya, Dr. Adrian will
Yeah,
explain.
yeah. Okay. Okay. Or you can just write in the chat. I know that some of you are still writing question. I
Some of them
hope.
are very shy. It's okay.
Yeah.
To talk, you can talk. It's okay. Nggak ada masalah. Broken English ke? Saya pun bisa dulu broken English ya. Practice makes me perfect.
Yeah.
Okay. So no problem. All of you has the potential to become the good leader, whether you want it or not. So take the opportunity. If I have the opportunity like this before when I was undergraduate, I think maybe I know more. Last time it's only just the lecturer teach, and then we never had opportunity to listen so much from international speakers. You see?
Yeah. Because today's era of disruption, easy to get the information.
Yes. So you guys are in a better position, and I
Yeah.
have trust in you. So the most important thing is to learn from people that has experience. Maybe we also make mistakes so that you can learn from us.
Maybe I will start with the question.
Bisa?
Then I hope, yeah, somebody else will follow. So, Dr. Hazin, it's quite interesting how you approach to the study to get the information about behavior because uh, of course that so many study from biological study and let's say state of art study they are very yeah, expensive and very go to detail, but at the end we are talking about the people, we are talking about the society where and that type of study is quite or is most impossible to be implemented to community. So but then how do you think the biological aspects are I mean, what is the contribution of the biological aspect you explore as compared to behavior? Do you find any dominance in between of these factors?
I know this is this question is actually very good because you see, behavior is something that we cannot see so much, and normally there are various tools to look to behavior. And I'm not really focusing so much on behavior except for the adolescent. But why I'm actually showing as a bigger picture, because most of the time we are focusing as people who are either in the diet background or nutrition background. We are so focusing with our expertise until we've forgotten that the
Mhm.
person that receiving our information don't really care or don't even know.
Yeah.
Okay, so the point from my study is actually first understand what is their problem. The issue here, for example, even though with our low income, 90% of those who are participated in my intervention study already overweight, obese. Can you imagine that? So the issue, even though they have hypertension, they have that, we must look into, is there any place that they can do physical activity, or how relevant we can make it. So with your study, why it's important to have or understand a little bit more behavior, because that gives some idea for us to look into how we're going to plan of our intervention. Because if they are low income and they are stressed, they are also having more fund money is more towards buying cigarettes, then you really need to think about whether additional or food subsidy working with another NGO potentially going to work. Because you see, if you keep on educating, we never know what is happening at home. At home, maybe the wife wants to cook healthily, then the husband want to angry with her. You got what I mean? So the complexity needs to be understood. So once you know a little bit, that is where I think I didn't talk so much about qualitative for this group, maybe for future. Maybe for some in nutrition study as well, qualitative is very important, because that is where you're going to plan how you're going to do for your intervention. So having the biology, just now you mentioned, that is making stronger justification and also helps for your publication. Because you don't want whatever, let's say, let's say for your case, Undip giving you 100,000, not 100,000, I don't know what's the, let's say $50,000 for research. No matter what you want to show your behavior and everything, they still need to see how this can be implemented, whether it can improve in terms of their, I would say not just biology, the physical attributes, because changes in diet and everything. So having those both together will strengthen your study and also strengthen your development of policy. I hope I answer you there, because this is actually an issue. Most of us if you are as a medical doctor, they are focusing on just looking to disease, but then they will forget about nutrition, example. And then when it comes to nutrition, we always say, oh, very important nutrition, but nobody wants to listen so much, because they say, well, we know nutrition important, but then everything's so expensive. I've been abused. I cannot buy food. How I'm going to do it? So we must understand how we want to come in, and then only it will work.
Yeah, very clear. Yes. So this is also important notes from Professor Hazreen, that biological needs to be taken into account to concise or to determine our goals.
Yeah.
But to go there, yeah, we have also should should take account, yeah, as you say, that the behavior, the maybe from the economic side, from the after we explore about the population target of the study or policy, something like that.
For example, for student, either you ada masters ataupun kedoktoran, ya, PhD, maybe ada join di sini. When you are going to do your study, I know we are focusing on nutrition, we want to give intervention, what would be the best, but not to forget basic determinants such as their education, their income, because sometimes I notice a lot of us discovered fantastic finding, but then their basic information such as the background, the education and everything is not there, because sometimes those things also play a role when you're going to plan for your education. If I'm talking to all of you, I don't need to talk so much. I just give you a link. You can learn yourself. But if you go to this low income group, you must make it fun. You must make it there. And this younger generation, like the students from undergraduate or postgraduate, you have a better opportunity because everything is in your fingertips. Okay. Even though my daughter now doing CapCut or whatever it is, I have no idea what she's doing, but at least it's something for to put for as a education material. So that is one thing. Coming back to sometimes with biology, biomarkers, if you have lecturers who are having some grants to take blood, which is fine. But then if you don't have, basic things not to forget is actually minimum of weight and height, and also waist circumference if you are doing something got to do with the community. Yeah. Okay.
So I hope this stimulates the audience to ask. So please because from the master students who are present here, there are a new how do you call it, new academic year, but also there are some students also from the previous academic year, which is actually they are in part of developing a proposal or yeah kind of things for research. So I think for those of you who are preparing, you can ask.
Adakah? Adrian, maybe in the future, next year, we have to plan properly for adjunct professorship. Then we have
Yeah,
several session of the research, and then I think your department
yeah,
is
we, pardon?
your department is big. So I think
Yeah, yeah,
some people are doing community, some doing very food science, some are doing clinical, I assume. So
yeah,
different study has different study approach and design.
yeah.
But I guess that will be for next year. We can plan if I'm still wanted by Undip.
I think that's good idea because of indeed that we you are correct that we have quite variety of interests of study, uh, both from the lecture and also from students. So I think making a kind of not webinar, I would say like a summer course series, something like that. That would be more, yeah, more targeted. So we can create a particular topic, and then so for those who are interested only, and then inside of this we will have a very nice discussion and maybe very nice idea
Yeah.
to create. I agree with you. I fully agree with you, Professor.
Yeah. Any question? I think somebody want to say something. Jangan malu, jangan segan, jangan leave lagi selagi tak diambil gambar satu kelas ya. Any question? Don't feel. If no question also is okay. But Suci ni Suci yang sama yang pergi same lecturer ke juga? Your group or different name? You remember last time your Adrian in the one that we went CNLP?
Yeah.
Ada nama Suci, tapi not this Suci.
No, I think not this one. Yeah. No. We have Hartanti. I think at the time we went to the CNLP.
Okay.
Hartanti was master students of CMEO.
Okay.
And she was graduated already, and she is now being a lecturer in our department.
Congratulations. Oh, that's
Yeah, but I'm sorry that she cannot present because yeah, today actually we also have another event which is more related to the education.
Yeah.
Yeah.
That's fine. I think never mind if the session after this between us and the academicians, we can discuss further. No problem.
Yeah. So okay, if there is no question, so we, or perhaps I will ask the administration, Mbak Christine. Shall we take a picture first? Okay, I think I have note from my message from my personal message that we should take a picture together of us before continue to particular discussion between lecturer and Professor Hazreen. So please turn on your camera because I will take a picture of this lecture. Okay, from the first slide, from the first screen, 1, 2, 3. Yeah, and then we go to the next slide. 1, 2, 3. Yeah, we go to the third.
Make sure they turn on their camera.
Yeah, the third, I think majority of them are still off camera. Okay, 1, 2, 3. And the last one, 1, 2, 3. Okay, thank you. Am I still have the opportunity to ask Dr. Hazreen? Because
Yeah,
I have question regarding the maybe this question is out of context, but
okay.
it's more about systematic review in this topic, particular topic, behavior, public health, and nutrition. So I think from when we would like to conduct a systematic review, what do you have experience or you know what type of keywords that we should emphasize to get the information about behavior? Because there, I think this behavior is part of social science in a way to get the information about definition, what aspect of behavior, and it's not that easy to uh, uh, to use the particular keywords. Why I ask about systematic review? Maybe uh, based on systematic review, we may have the newest information or at least the situation of current study about the behavior and nutrition. That's the question.
Yeah.
Perhaps you can share something about that. Thank
Yeah,
you.
I might not be the best expert for behavior change, but I think when you talk about behavior just now, there are several components. One is actually your capacity. So when you're talking about
Uh-huh.
systematic review, you cannot be so broad as well. When you're talking about in terms of diet,
Yeah,
the capacity of who, the individuals or what? That is maybe one systematic
yeah.
review by itself.
The
Okay.
the capacity of certain population, for instance, like
No, I'm trying to say in my slides just now, I do have capacity, opportunity, and then motivation. Remember? So
or
the
dietary
behavior,
pattern and nutritional status in specific type of population.
okay. So normally when it comes, I'm talking about just now, when you talk about behavior, we are looking from the beginning, capacity, and then we have the opportunity, and then the, not say manpower, motivation. But normally for most systematic review in nutrition, they are focusing more on motivation. They are looking at systematic review, how motivated the patient or the subjects when we are doing some sort like a intervention, behavior changes, and to see whether in 6 months time or 12 months time is going to be improvement. So that is one systematic review you can have a look at. The other one is actually people look at in terms of because you see for nutrition related diseases, right? Let's say we're taking just the obesity. Systematic review, maybe we can look into obesity, motivation, challenges, and so on. But our main challenges just now is going to be difficult if you want to look because challenges and barriers, people don't do it as a quantitative study. So if don't do quantitative study, they normally will explore, I think some of you know, qualitatively. Because facilities, various people don't normally just tick the box, right? Oh, I cannot do this program because it's too boring. You know, they need to know, understand more. So in this scope, possibly another way rather than systematic review, you need to also look at scoping review, where they combine both the what we call it quality and quantitative information. So to answer your question, must be able to go back what is the main objective and the target audience that you want. Because systematic review itself is a very long and complex. But when we want to come with behavior and everything, if they do have quantitative information, means the one that we can do analysis, SPSS or whatever R or you're using, you have that information, you can do it as systematic review. But if you don't have so much, then you actually look into the scoping review, would be another way. So your keywords there normally shouldn't be more than 5 or 6, but then you must be able to understand there is a combination between this and this, this and this. Okay, I hope I explained a little bit, because when it comes to behavior, Adrian, is actually more complex than the quantitative information only.
Yeah, that's why. That's why it's not that easy if we go only if we looking for the quantitative aspect only, and behavior is not quantitative
Yes. So
aspect per se.
That's where when we are saying to you, for example, from our work, we are trying to look into a policy on reducing salt from the ministry level of industries. So there's no way you're going to get information just using quantitative. So we need to do qualitative. So when I said to you just now, it really coming back what you want to do, but I'm more than happy to share with you some of those things that we already published, so you can have a look.
Okay.
And I think these are the things that maybe for future, like you say, your short course or whatever, you want to do it adjunct or whatever, I'm more than happy to do that as well.
Okay. Yeah, I think for me is clear in terms of how to approach to my question based on your explanation.
Yeah.
So, okay, if there is no question from students, so perhaps because after jadi can I speak in Indonesia? So jadi setelah ini ya, jika tidak ada pertanyaan, mungkin Anda semua bisa meninggalkan Zoom ini karena memang akan dilanjutkan dengan diskusi antara departemen dengan Prof. Hazreen. So we still have actually more or less 5 minutes for a question. So, but if there is no question anymore, so dengan hormat saya meminta nanti jam 10.15 atau ya 5 menit setelah ini bisa leave room begitu ya, leave Zoom ya.
Hampir